The logo on the left side is Universal Nairobi. The middle one is African Mental Health Foundation. And on the right is World Psychiatric Association for several reasons. Number one, I represent the World Psychiatric Association in most of Africa, and also African Mental Health Foundation recently was designated and WP World Psychiatric Association Center for Training and Research in Mental Health. Now, this is a very important statement that came out from the United Nations 31st, the last day of 2010, and it was flashed around, and I think I got it the same day. I must have been in the office or the following day, and read something like this: recognizing that mental health problems are of major importance to all societies and are significant contributors to the burden of disease and the loss of quality of life, and the huge economic and social costs, and went on and on. And this was the first time that the United Nations General Assembly for a long time was making a mention of mental illness or mental health. And that was a significant development. I think it culminated in a meeting that was held last month in Washington, where the World Bank and the World Health Organization and other bodies go together and started talking about mental health for the first time. World Bank interested in mental health. That was a very significant development. What I have here are things that you very well know, and I will just go through them very fast. Mental disorders account for approximately 10% of global mental health disease, burden of disease, as indicated by various organizations and bodies, including World Health Organization. As a group, they are a leading cause of disability worldwide. Common challenges in addressing prevention, treatment of mental disorders, and promotion of mental health, and the realization that there are global influences, underlying global influences on mental health, such as conflict, climate change, or macroeconomic policies, created a need to develop a global perspective. And this is what has been said by previous speakers today. A core focus in global mental health is to both reduce the overall burden of illness and reduce and ultimately, hopefully, eliminate health inequities within and between countries. The responsibility for improving global mental health, therefore, goes beyond national borders, class, race, gender, ethnicity, culture, and requires collective action based on global partnerships. Now, are there similarities between high-income countries and low- and middle-income countries? Yes, there are a few, and I want to mention just a few. Nearly all epidemiological data suggests very strong that all types of mental disorders are found across both high-income countries and low- and middle-income countries, making the need for service essentially the same. Basically, we are the same. I think it was Lambo who one time said, all people are the same. What differentiates them from time to time is culture. Access to mental health services is still not universal in both high-income countries and low- and middle-income countries. And although it is about 35 in places like Canada and 80 in places like Kenya, slightly more actually, more than 80, the fact that no country has achieved universal access to mental health means that not everything is functioning optimally. And I've been in Canada here for the last 1 week, and I have heard this same thing said over and over again. Mental health literacy in high-income countries is not as optimum, although the situation perhaps is worse in low- and middle-income countries. And the fast-growing interest in epigenetics suggests that in both high-income countries and low- and middle-income countries, there is a complex interaction between genetics and the environment in all its diversity, and the development of cause of mental disorders in a way not completely understood, whether we are dealing with the high-income countries and low-income countries. But then, having said that, having talked about the similarities, there are some differences. A more significant treatment gap, as I've just said. There is poor, limited allocation of financial resources for mental health. Despite being home to over 80% of the global population, the low and middle-income countries command less than 20% of the share of mental health resources. Many countries spend these clinical limited resources on ineffective and often inhuman practice for lack of local evidence, local-based evidence intervention, underlying evidence-based effective intervention. There is widespread violation of the human rights of people with mental illness. There are high levels of psychotrauma as a result of armed conflict, gender-based violence, and sporadic political instigated violence. Human resources, mental health are inadequate and inequitably distributed with a bias for urban areas, as I'll show you in a moment. There is widespread stigmatization and social exclusion of people with mental illness. Now, I want you to look at some of these statistics just to show you the difference between low and middle-income countries. You can see mental health workforce per 100,000 population in different WHO regions, and you can see the red circle is really very low compared with Europe, and I think Europe is a combination. The reason perhaps why it is much higher much better in Europe is because in the American system is a combination of both North and Southern America with different levels of development. And again, when it comes to population ratio, again, the red square, the little rectangle, you can see is very, very small, 0.1% compared with the 7% in Europe. Now, I've told you there are similarities calling for making the demand for service or the need for the services similar, but there are also differences. Now, the question that is important for us, particularly we in developing countries, are we going to say the situation is hopeless and we do nothing, sit there and wait and do nothing? And I'm saying we can't do that. We have to do certain things, like provision of evidence, informed intervention and support, like what we have just heard from Fred. And I want to congratulate this gentleman for many reasons. I think sometime he came back to Africa and toured so many places and encouraged us. And I've been following with interest what he has just presented to us, and you can see it is working. There is intervention that is working. Cost effect is developed within the context. The opportunity for increasing awareness and literature on mental health to minimize stigma, and we're using some data again supported by grants. You guys, Canada, I just want to thank you so much. I don't know whether you know the difference that you have made in some. Let me talk about Kenya, because it's most of this work, some of the data that I'm giving you and what we have heard from Frederick is because of the grants from Grant Challenges Canada, which is government money. It is your money, and you've given us this money to do research, and we are beginning to make a difference. Please, I want to say thank you very much to you. Increasing awareness of the rights of people with mental illness, their legal capacity in terms of ability to make informed decisions and act on them, and improving their social inclusion and economic participation. We have heard about economic participation, and therefore breaking the vicious circle of mental illness and poverty. Greater involvement of key stakeholders. I'll spend a little bit on this as I go along because it's very, very important. Greater involvement of key stakeholders and the policymakers. We need to work with the policymakers. Some government leaders, as or non-governmental organization, And for us in Kenya, we are beginning to do that for the very first time. And as a matter of fact, again, through a grant from the grandchildren in Canada, there is a government, we have 47 county governments, there is a government who have said for every Canadian money that is put into mental health, they will put $1 from the taxpayers' money. These are not my words. These were the words of the governor of Makueni County talking to Peter Singer in his office. That is, he came all the way to Kenya to see this. And this is what he told Peter Singer in my presence. And as a matter of fact, they have done that because we've been able to demonstrate that locally generated intervention can actually work and produce some results. I need to move fast. Collectively, these factors, all of us working together, create the possibility of introducing and implementing more sustainable mental health services through bidirectional flow of knowledge and expertise between us and you. Let me just make it contextualize. You Canadians, people from this part of the world, and from that part of the world I come from. Now, you have specific expertise that needs strengthening, which we could make use of. Skills in competitive professional development and grant writing, I think, is very important. Biostatistics, things you guys take for granted, they are very important for us. Knowledge translation and exchange, publication, program management, monitoring, things that are going to make a difference. Now, for all of these, for us to be able to achieve this, we need to be innovative. And I want to pose two questions, which I alluded to a little bit earlier on. Can we, people in low and middle income countries, ever catch up with the high income countries in human and financial resources for mental health? The answer is no. I think is not unusual for, I don't know how many psychiatrists you have in Montreal or you have in this hospital. I reckon that they could even be more in one hospital than all the psychiatrists in Kenya. We have 90 psychiatrists in Kenya, and I've had the privilege of training 90% of them. Frederick will tell you because he came to see what we are doing. So we cannot say we are going to wait until we have as many psychiatrists as we have. The other day, somebody said, according to WHO, we should have 4,000 psychiatrists in Kenya. And he was actually telling the government so. And actually, that's a total number of doctors we have in the country. So when are you going to get before that? According to WHO. And I think somebody said we must contextualize our needs. Can we afford to wait? The answer is no, we cannot. We must do something with the resources that we have at the moment. We must do something. And therefore, for us to do that, we must be innovative. And as we look for intervention that are effective or that we want to put in place, we must be guided by certain qualities. We must be affordable, that is within the prevailing economic status of the country, where, like in Makueni, 60% of the population live on less than $1 a day. It must be appropriate, effective, and evidence-based. It must be available. People can make informed choice on whether to take them or not. In the case of Frederick, they can decide to go to take the intervention that they use, or go and see, look for other ways of intervention which may not be cost-effective. And they must be accessible, located within fiscal reach of the communities. People do not have to travel 300 miles. They take 2 or 3 days to go and see a psychiatrist who is not available. We have heard about some of these. I don't need to go into this mental. These are some of the other things that we must do. In order to be able to do this, we must harness all the resources for mental health. We have mental health workers, psychiatrists, very few counseling, clinical psychology, very few nurses, psychiatrists, social workers, informal lay workers, faith healers and traditional healers. We have plenty of them, community-based workers, recovering patients, and other disciplines. And I have come to realize part of the problems in we psychiatrists, let me talk about we psychiatrists, in taking services to the people, is the assumption that we have been very highly trained and therefore we are the only people who can do that. And I'm telling them, no, we can't do it alone. We need other people. We need social scientists. We can't do without them. We need health economists. We want them to tell us, is what we are doing, is it cost effective? Is it worthy? Is something that we can recommend to the government. We need to work with the anthropologists, and we need to work with the media, as Frederick just told you. I can tell you we didn't compare notes. He spoke on his own, I'm speaking on my own, but we are speaking same language. Other NGO, community-based organizations, human rights groups, and as so we cannot sit here and mourn back in Kenya that we have 90 psychiatrists for one psychiatrist for 500,000 people, most of them in rural area, in urban areas. We just can't sit there. There's nothing we can do. We are so poor. Sorry, there's nothing we can do. There's a lot we can do with the resources that we have. And the many other people's community, policymakers, collaborators, researchers, and so on. So it's a question of identifying the resources that are at your disposal and work with them. It is exactly because of these reasons that we started the African Mental Health Foundation. I think when I had spent a lot of my energy training psychiatrists and went around saying we are doing very well, one psychiatrist for 500,000 people compared with the surrounding countries where they had one population for 1 to 2 million people. I thought we were doing very well until I did an audit and realized that most of these psychiatrists were actually in urban areas and we are not accessible by people who need them. Now, this is just an example of the things that we've been doing to bring people together to talk about mental health. Here in this group, you have everybody. You have people, you have nurses, you have clinical officers, you have faith healers, you have community health workers, all sitting together in a room like this and saying, this is our problem for all of us. Can we talk about it as equals? Yes, I can provide the leadership and so on and so on. But in most of these meetings, when I go to them, I don't want to sit at the high table. I want to sit at the back and to contribute like everybody else. And we found it to work. Now here is what are we doing here? All of these are traditional healers, and there are very many of them. Every village has got several of them, and they are patronized by patients. They are liked. The problem has been we medical people, we don't want to work with those people. They never went to school. We call them all kinds of names. And they tell us, okay, fine, you can keep your university degrees and the papers and you will keep the patients. That's what they tell us. And we have found a way of getting these to people to talk. It was very difficult negotiating getting these people to talk, but I think we are talking. I think there's a paper Lawrence published where we were talking about dialogue. Again, faith healers, these are people who are preachers, and we just want them to understand mental health so that when they see a person with the depression, they don't say this person is evil, is possessed by the demons, or is not. His mental illness, it can be handled. So, what I'm saying is that yes, there is hope that we can provide services. It can be achieved. This is a dream that calls for innovation, but particularly involvement of all stakeholders in the communities and the global arena through partnership. Together we can identify the opportunities, which I've just said, their challenges, and work towards overcoming any barriers while maximizing on the opportunities. In the interest of time, I will skip most of this because in many ways I'm saying the same thing in different ways. So By harnessing all these resources, for me, there is hope for mental health for all in less than 10 years if only we embrace these innovations. The WHO published a document in 2013 called Mental Health Action Plan 2013 to 2020. And when it was published, we thought they were joking. But now, in one county, where the government is willing to work with us, and we actually did initial work and demonstrated to them that it can work, they have said it's going to be part of our services. We are going to integrate it. When we talk about maternal child, when we talk about tuberculosis, when we talk about HIV, when we see patients at the health centers, we'll be talking about mental illness, and we are going to provide services. They have even made drugs available, so we have no problem with psychotropics. In fact, they come and tell us, "Do you want more?" So we tell, "No, you can do with this." So, with goodwill, it can work out. Now. There's a story behind this, but let me just leave it like this.